Hello, welcome to EASL Studio, your hepatology broadcast news, live from ILC, International Liver Congress. I am Pierre-Emmanuel Rautou, a hepatologist at Hôpital Beaujon, Clichy, France. And today we will debrief what happened today at ILC. And I will moderate this session together with Professor Debbie Shawcross, a hepatologist at King's College, London, UK. And we are very happy to have with us tonight three distinguished persons. First, Professor Pere, who just received an award, and we're happy to congratulate him for this recognition award. So Professor Pere is the head of the Department of Hepatology at Hospital Clinique in Barcelona, Spain. We also have the head of the Department of Hepatology in Paris at Pitié-Salpêtrière, Dominique Thabut. And we have Mattias Mandorfer, who is working at the University of Vienna in Austria. So, Debbie, I'll let you start with the first question to our invite.
Of course. So Dominique, there was a fantastic second session this afternoon, which I believe you were at, and there was a beautiful study on HCC that was presented. I wonder if you could share your thoughts with us on...
Yeah, sure. This was a big trial coming from France, which was initiated, in fact, 10 years ago. So it was a little difficult to include, and presented by Cyril Pere from Paul Brousse Hospital. This is a multi-center trial. And the objective of the trial was to compare in patients with HCC eligible to chemoembolization alone, 1 or 2 or 3 sequences, and chemo, and then conformal radiotherapy, so standard radiotherapy. So just one time chemoembolization and then radiotherapy. So in fact, the topic was a little hot because we already have 8 positive studies, all coming from China, and 2 meta-analyses in favor of adding radiotherapy to chemoembolization. But no study from Western countries. So this is the first study in the Western countries. And in fact, 120 patients were included and randomized, and this is really really a negative study. Negative study on overall survival and on progression of the tumor. So everything is negative, and really there is no benefit. But there is also more adverse event in the group of radiotherapy, with a lot of portal hypertensive events, which is quite interesting. So right now...
You have got an idea of the link?
Well, my idea is about inflammation. We don't know, in fact, but probably inflammation is playing a role here.
But it was, portal hypertensive related bleeding?
Yeah, okay. And this was not known. So this is really important. So negative study and portal hypertension increased with related events with radiotherapy. So, well, this was counterintuitive, and those are the results of a well-done study with blinded assessments of radiology and everything. So I think that we can really believe those results, at least in Western countries, in Caucasian patients.
And you have an idea how to explain this discrepancy between this French study and all the study you mentioned
before? I
before?
think the populations were not the same, Caucasian and Chinese, first thing. Second thing, probably the protocols were not completely the same, and I'm not sure that in the Chinese study everything was blinded, So probably we should go more into detail. Okay. But those are my hypotheses.
And do you think the etiology of the liver disease might be important here?
Probably.
Because I guess the Chinese is more viral hepatitis.
Probably because we had a lot less of chronic HBV, of course, in France, and a lot of alcoholic patients. So maybe that's also an explanation. Anyway, the results are the results, and so we have to keep that in mind. Now we have a lot of new treatments coming for HCC, and probably radiotherapy, at least standard radiotherapy like that, won't be in the game anymore.
Of course. So anything else that really caught your eye today?
I was at this ACLF session this morning that you were chairing, and there was this study of Engel coming from Padova, NGAL as a new biomarker of HRS. And I thought it was really interesting because we are sometimes struggling to say, well, my patient has renal failure, is it HRS, is this tubular necrosis, is this something else, hypovolemia, and what to do with that? And so NGAL is a new marker. I don't have the experience of NGAL myself, but I know that we could do it. And here, this was a large series of patients who were included from Padova, and the NGAL was studied. So at 39%, as far as I remember, of the patients had HRS, and NGAL was significantly more elevated, a lot more elevated in patients with HRS. So it was very useful for the differential diagnosis of HRS. And then also in those patients treated with terlipressin and albumin, I must say that NGAL, with certain values of NGAL, I think it was 220, but I'm not sure, were correlated with the response to treatment and also mortality. So those results need to be commented, and I'm very happy that we have Pere here to comment them. But it caught my attention because I thought, well, maybe we will just sort out the story of is it HRS or not, and how should I treat it? So.
Yeah, Pere, I saw this morning you went to the microphone and had some comments regarding this study. And we know also that you have a great experience with NGAL and published on that. So could you share with us your view and what is your take from this study?
Yes. Well, I think this was a very good study, you know. And in fact, in the area of acute kidney injury and hepatorenal syndrome, we need objective markers because so far the definitions for the differential diagnosis are, let's say, quite subjective. So it's difficult to make the diagnosis if a patient has acute tubular necrosis or hepatorenal syndrome or another cause of acute kidney injury. And the fact that we could have in the future biomarkers to be tested easily in the urine may help the physicians a lot when taking decisions about what is the therapy that should be given to the patients. And I think that this study is important because first it confirmed two important things about NGAL, which is that it is very helpful in the differential diagnosis between acute kidney injury due to acute tubular necrosis or hepatorenal syndrome. So the levels above 220 are highly suggestive of acute tubular necrosis. By contrast, the levels below 220 are highly suggestive of hepatorenal syndrome. So this is the first important message.
On the practical point of view, it means if you have high level, you should not treat with terlipressin. Is that the clinical implication?
Exactly. So if the levels are very high, the suspicion is very high that the patient has marked necrosis or at least marked injury in the renal tubules. So very low probability of hepatorenal syndrome. Second message. Yes, please.
But how would you approach the patient then? You know, we only have one treatment. How would you approach this problem?
The problem of treating the patient?
Of the patient.
Of course. You know, because the two important causes of acute kidney injury in clinical practice are hepatorenal syndrome and acute tubular necrosis. For hepatorenal syndrome, we have terlipressin, and we have the good news that terlipressin will likely be approved soon in the United States and Canada. It is available already in Europe and will be approved in North America. For acute tubular necrosis, we know that terlipressin is not effective, and we know that the patients, if they meet criteria for hemodialysis of other types of renal replacement therapy, they should go to renal replacement therapy until we have better treatments for acute tubular necrosis. So in this regard, the fact that we have something objective will make things much easier and will make studies much more comparable. Because so far, if there are no objective measurements, it is very difficult to compare studies from one to another. Second message is that those patients who have high levels of NGAL in the urine have a much poor prognosis. So this is also important with respect to the evaluation for transplantation. So this means that patients with high NGAL are more likely to die if they are not transplanted soon. And we have shown that the NGAL adds value to MELD. So a patient with high MELD and high NGAL has much poor prognosis compared to a patient with the same MEL and lower end-gall. So this is the second important message of the study. Third important message is that they found a relationship between, in patients with hepatorenal syndrome, between the levels of end-gall in the urine and the response to terlipressin. And this is something that, if it is confirmed in other studies, would also be very important, because before starting terlipressin, we will be able to, anticipate which are the patients with a higher likelihood to respond, so to start terlipressin therapy. And this is important in the light of the results of the confirmed study, suggesting that some patients may be at risk of developing acute pulmonary edema. So in summary, this is, I think, is very important, adds to what we know about end-gall, and will probably change the next guidelines in the sense that probably end-gall will be incorporated.
But you have published already some years ago on end-gall. Are you using end-gall in clinical practice at your site?
We are using end-gall at clinical practice. And in fact, we have a system.
How do you manage these numbers on a practical point of view?
Yes, what we are doing is that we are giving first albumin to the patients who have acute kidney injury for 2 days. And then if acute kidney injury persists, then what we do is that we measure end-gall.
In the urine?
In the urine. If we have a system that is called turbidimetry, in which we have the results in 3 or 4 hours.
Okay.
So you send the urine to the lab in the morning, and in the afternoon you have the values.
Okay.
So if the patient has very high end-gall, above 220, it's very likely that the patient has acute tubular necrosis.
And is there something about the volume of urine to take into account? Because we could imagine that if you have half a liter or 2 liters of urine per day, it might change the levels. Is that something to take into account?
This is a very good comment, but as with many other substances that are eliminated in the urine, if you factorize it by the level of creatinine in the urine, you eliminate the problem of low urine volume. Okay. So in fact, it is better to give the end-gall results by gram of creatinine in the urine.
Okay.
Because actually, Pere, in the session this morning, there was also another group that presented some data on end-gall in another abstract, but also they were looking at urinary microscopy and showed that there was quite a good correlation just looking at the urine, looking at CAS. What are your thoughts there? Is that something we could use?
I have spoken with several nephrologists in our hospital and in other hospitals, and urinary microscopy is something that the nephrologists in general sort of have abandoned over the years, and they do not use very much in clinical practice. And I think that the guidelines, with respect to the nephrologists' use, do not incorporate the evaluation of urine microscopy. And in fact, in many hospitals, it is not available. The advantage of end-gall is that you could set up it in any lab, in any hospital, so it can be available.
In conditions that is not very reliable, which we would assume for tests that we would recommend in the guideline, right? Because if you're lacking the experience, then...
Exactly. And end-gall is something which is very objective and, low variability, so I think it's much better than something that can be more subjective.
Okay. So I have the feeling you like this study.
Amazing biomarker.
Well, did you like other studies today?
Well, there was this study of David Shawcross group about hyperammoniemia. And I think that this was also a very good study because,
You're saying that because Debbie is there?
Or? No. I think that because the studies that are looking at factors that predict the worsening of patients with decompensated cirrhosis, that is the development of acute and chronic liver failure, they are very important. And we need to look for factors. And this study was good in the sense that it showed that patients with high values of ammonia are more likely to develop acute and chronic liver failure. So I think that this is a very good study, and I like it because of this.
But how does it work, Debbie?
Yeah, so essentially we've realised that there's a lot of inflammation in patients with decompensated cirrhosis and a lot of mitochondrial dysfunction. And ammonia is a toxin, and some of these patients have really, really high levels. And I think what we wanted to do was to collect data. So this is a study that was from 4 centres, 2 from Spain and 2 from the UK. and Rajiv Jalan was the other principal investigator along with myself. And what we've done is we've looked at a baseline ammonia level and then followed these patients through up to 5 years, although in many cases, sadly, not all these patients survive 5 years, and looked at how it determines their outcomes. And it's a very, very good predictor of mortality, but also development.
At baseline, once
yeah.
it predicts the outcome at 5 years.
Yeah.
Wow.
Yeah.
And if I may, what is very important here is that we really needed studies in outpatients. Because when the patient is hospitalized and has high ammonia, we know that this is a prognostic factor, and you guys publish very nice studies about that. But what we need is a marker when the patient is out to say, well, if he's there, he's going to go and decompensate.
Yeah.
And then I have to think about, well, either listing or watching out very carefully, or maybe treat that. And the real question here, and we don't have the answer, but that's what I wanted to say, is that we as a community have to answer the question, would it be worse to lower ammonia in outpatients in order to prevent the complications? And this is really, really, really important.
Okay, so is that in a sense a biomarker, or is that an actor driving the outcome of the patient?
Well, it's difficult to say, but I think you can think of it as a biomarker. And I think the thing is, people have always associated elevated levels of ammonia with encephalopathy. Yeah. But actually what we're realizing is that some of these patients didn't even have encephalopathy. They had ascites, all sorts of other things. But actually it's still a really, really important factor for determining their prognosis. So I think we perhaps ought to stop associating ammonia just with encephalopathy.
Okay. And there was discussion, I remember, during preparing the EASL guidelines on hepatic encephalopathy on the pre-analytical conditions related to ammonia. Should that be arterial, venous, transported in a certain manner? So how is that? Was it done in this study?
Yeah, so it's a very, very good question, because in our centre at King's, we did arterial ammonia levels, which is something that we always do at a baseline. And we frequently do it actually at transplant assessment as well. So we're assessing patients for transplant. We do a baseline ammonia level. But some of the other centres, the Spanish centre, did venous levels. Okay. But actually, what we looked at is we actually looked at the level compared to the range in that hospital. So we did a sort of upper limit of normal, a bit like an INR, a ratio. So rather than looking at absolute ammonia levels and saying, well, the ammonia level here is 50 and over there it's 100, we looked at looking at a fold change in ammonia. And that's actually quite helpful, whether you do venous or whether you do arterial.
And what is probably important also is the evolution of ammonia levels in a certain patient. Also, probably.
Yeah.
But it offers some opportunity, and I think this is something that we are lacking. We have this pool of decompensated patients, and limited amount of these patients will progress to ACLF in a reasonable amount of time. So actually, the number needed to treat for any treatment will be quite high if you take all decompensated patients. And then for ACLF, we are still lacking, except for, of course, liver function parameters and so on, good pathophysiologically oriented biomarkers for risk stratification. Of course, we have the inflammation, but that may not be so pronounced in patients who are clinically stable and outpatients. But it could be that there are other biomarkers around that are related to this inflammatory context that actually could be used for risk stratification, and then you could select the appropriate treatment candidates for prophylactic measures, such as evaluated in the liver hope study, for example. Okay, so Mattias, it leads me to a question, because I saw, I think, a poster today where you were slightly implicated around biomarker portal hypertension. Maybe you want to comment on that, those data, and to what extent it could be useful to what you are mentioning, meaning stratification of the patient. Yes, at Baveno we are right now a step earlier, so we want to prevent the first hepatic decompensation. And for this, the new hallmark with Baveno 7 is CSPH. So this actually guides our treatment decision in regard to using carvedilol to prevent like this downward spiral where these patients are already at. And the problem is that now we have this Baveno 7 criteria where you can rule out CSPH confidently if the patient is below 15 kilopascals and has normal platelets, or if it's above 25, then you can rule in CSPH, but the gray zone actually is more than half of patients. Clinically significant portal hypertension. Meaning so HVPG, hepatic venous condition that would require carvedilol treatment or non-selective beta blocker treatment, according to the Baveno 7 guidelines. And the problem is that the gray zone in between this criteria is more than 50%.
So you mean between 15 kilopascal and between 25
Yes.
kilopascal. So your target is this area where we are not comfortable and we want to better...
Well, we actually don't know if a patient has CSPH or not based on the established
Okay.
non-invasive criteria. And there's been recent work on spleen stiffness, but we also assessed now the Rautou score, so von Willebrand factor
Is it the
divided by platelet
What
count.
is the Rautou score?
So it's von Willebrand factor, a marker of endothelial dysfunction, divided by platelet count as a marker of portal hypertension. And the ratio of these two, it's actually, if it's below 1.5 in the gray zone, then you can discard CSPH. If it's above 2.5, then you can rule in. And it's same with for spleen stiffness. In the end, if you add like the third marker to liver stiffness and platelets, then you end up with having 90% of patients classifiable. So you can make these treatment decisions to prevent the downward spiral very early with quite a high confidence.
Okay, so you address this gray zone and try to go even further in the stratification of the patient non-invasively.
Yes, and I think this could also be an approach to decompensated cirrhosis, that in this clinically stable outpatient setting that we're already stratifying patients who may benefit from treatment strategies, because right now what do we have? We have a Ascites protein to stratify for norfloxacin use. We have actually this long-term albumin treatment with no real biomarker for that. We're just basing that on disease severity. And then our disease-modifying treatments, except for TIPS, we already came to an end. And I think we really have to move forward. And also for this, I think risk stratification in decompensated cirrhosis, as we do it for compensated cirrhosis, would be very important.
The Rautou score, meaning...
It could also work in this setting, possibly. We know that von Willebrand factor as a marker of endothelial dysfunction is also HVPG independently predictive of events in patients who are already decompensated. Okay. But of course, this is another question that has not been addressed today.
This is for ILC 2023.
Yeah, possibly.
But Mattias, you mentioned splenic stiffness, and there's actually, I noticed a lot of posters today on splenic stiffness. So do you think that's something that we should be doing more?
So I was very skeptical until recently, because I tried it a few times and I found it very hard. But now we've moved to shear wave elastography, and with shear wave elastography it's easier because it's just implemented an ultrasound device. And EchoSense has also produced now a new version of vibration controlled transient elastography, which has a spleen stiffness model. And if this is commonly used, then I could imagine that this is something that is also useful for the clinic, because we always need a test that is reliable and a test that is easily applicable. And with spleen stiffness before, this was not really the case, but I think now the development is like really speeding up.
So you start using spleen stiffness. What about you, Dominique? Are you using spleen stiffness?
Well, I have the same experience than Mattias. I tried, and it was like completely random, the numbers I had. So I said, well, I will move to this ratio, this vitro ratio, which is probably better. And now we are implementing spleen stiffness also with the Explorer, and so it's getting better.
What about you, Pere?
We use it just for research purposes for the moment. And we are waiting for more data to implement it in clinical practice, but we have the device, so we could implement it easily.
Okay, and you?
Yeah.
A little poll to know.
So yeah, research settings at the moment, really. Okay. So I was really interested to hear people's thoughts.
I was like Mattias. I was a little bit skeptical, and in fact, the data we have are quite good. So it seems. So it seems to be
like with everything. There's a learning curve.
Yeah. So watch this space next year. Okay. And any other sessions that you went to today that really caught your eye?
Also, aside from acute on chronic liver failure sessions and advanced chronic liver disease topics, we had a very rich program today. We also had a very nice session, an abstract session on rare diseases, where there was actually siRNA-based data presented. So a small inhibitory RNA that uses RNA interference.
In what setting?
It is for acute hepatic porphyria. It's already licensed, and it's also clinically available.
But this was data last year, isn't it?
Yeah, exactly. It's
so
like a long-standing EASL story. But this year it was the 3-year data, so the follow-up of the phase 3 study with very encouraging results, and very much looking forward to seeing more siRNA-based treatments coming up in our field.
What you mean is that the beneficial effect is not lost after a longer duration?
It is maintained, and very solid data that the that the frequency of crisis is substantially reduced.
Okay, side effect, are there something
Very
else?
limited injection site reactions, and that's it basically.
Okay, so sounds good. Maybe other studies using this technique will be presented maybe in the next days.
In the next days, there will also be a presentation on alpha-1 antitrypsin deficiency, which also uses an siRNA to knock down the Z protein, and this will be also something that will move to the clinic hopefully very soon, because it's an unmet need, and I think in more and more of these genetic diseases, we'll see these therapies possibly also as disease-modifying treatments in other diseases where they address genetic cofactors.
Okay. So sounds really promising. Big progress also in rare diseases. I was quite impressed by a study, the CLEARER study. It was in the session you were chairing, Debbie, and you were there too. Pere, do you want to comment this CLEARER study, what it was? Because it's a big study.
Well, this is a very large study that has been coordinated by the group in Virginia, by the Josh Bajaj group, and they were looking at hospitals in all different continents of the world. I do not remember, maybe they enrolled about 50 hospitals.
I saw more than 1,000 patients.
Exactly,
yeah.
You know, and so what the objectives were to look at what was the outcomes of patients that were admitted for acute decompensated cirrhosis, and what were the factors that were predictive of prognosis.
Okay.
You know, and they found marked differences
between what?
Between the different countries of the different continents. Well, they divided the countries between high income, low income, and medium income. And not unexpectedly, they found that the survival of patients with decompensated cirrhosis was different between the countries. Okay. This is something I would say that is not unexpected because it probably happens in other acute diseases. But I think that this is important to make awareness about this, because this may be in some ways improved, because apparently at least part of the differences were related to the access of patients to the intensive care unit in the different hospitals, and access to liver transplantation, which is something perhaps liver transplantation is more difficult to achieve.
Access to ICU, access to liver transplant. This is the hypothesis that could explain such a difference.
Exactly.
And if I remember well, there were other prognosis factors that were found systematically. I think it was infection.
One was infection, and probably is one of the worst prognostic factors, you know, for patients with cirrhosis, because infection is a driver of many of the complications of patients with cirrhosis, bacterial infections, particularly severe bacterial infections that require hospitalization of patients because they drive hepatic encephalopathy, they drive acute kidney injury, they drive acute and chronic liver failure, and finally mortality. You know, mortality is very high, particularly with severe infections, 30–40%. But this was important because we know that there are differences in the bacteria that cause infections among different countries and different continents. Okay. Particularly the percentage of bacteria, of infections that are caused by multi-drug resistant bacteria. And I think that this adds to the current knowledge with respect to difference in different countries, so that we as a community of hepatologists, we need to help the hepatologists working in countries that have difficulties in access of patients, for example, to several new antibiotic therapies, to the ICU or critical care for patients with decompensated cirrhosis, and finally for liver transplantation. So I think
there was no data for the moment on multi-drug resistance in this cohort, was it?
No. I am, you know, mixing this study with the
study. No.
But it was interesting, Pere, because actually there were some surprising differences in that actually some of the more developing countries, for example, India, had better access to things like rifaximin than some of the European and US and North America, because it was cheaper. Okay. And that was one of the things that they identified, which was actually quite interesting.
Yeah.
And the other factor was melt sodium, wasn't it?
Melt sodium was another. I think that these are also important because, you know, when we develop guidelines, in general, we develop guidelines for rich countries. Yeah. you know. And I think that, you know, the societies will need to work with hepatologists or physicians working in low-income countries to develop guidelines for complications adapted to the health care situations of these specific countries. And I think that this is something that also should be discussed.
Okay, so I think it was a really good discussion. I think
Yes.
it could last for
It could.
hours and hours.
It could, but sadly, I think we've run out of time. So I think what we need to do is say goodbye and to say thank you very much to our experts, to Dominique, to Pere, to Mattias, to Pierre-Emmanuel, and to say goodbye to our audience today. I hope you will have a lovely evening. And please do tune in tomorrow for EASL Studio London Calling and Midday Talks and our Tea Time episodes live from the International Liver Conference 2022. So thank you, everyone.
Thank you very much.
Good evening.
Thank you very much.
you.
Thank you.